gynae oncology session, and today is the session is our tumor board. And I would like to introduce all the faculties today. Our faculties today are Professor Dr. Vijay Ahuja sir. Sir, he is working in Monipal Cancer Comprehensive Cancer Center. Sir is the President Association of Gynecological Oncologists of the India. And second, the faculty is Professor Dr. Omita Moheshwari. She is always known to you all. Omita Moheshwari ma'am, she is the professor and head Department of Gynae Oncology, Tata Memorial Professor and Head Department of Gynae Oncology, Tata Memorial Hospital, Mumbai. And Dr. Rupender Shekhar, she is the Senior Consultant, Rajiv Gandhi in Gynae Oncology, Rajiv Gandhi Cancer Institute, New Delhi. And Dr. Raju Chaku sir, sir is the Director and he is the Medical Professor and Department of Medical Oncology in Christian Medical College Hospital, Vellore. And today we have with us another faculty. He is also the medical oncologist from Tata Memorial Hospital, Mumbai. She is Dr. Seema Gulia. Though her name is not in our flyer, but I have especially requested her and she joined with us. Welcome to Dr. Seema Gulia, ma'am. And also we have invited Dr. Santosh Menon, sir. He is the Professor of the Histopathology Department of Histopathology Department, and she is working on GI and gynecological malignancy in Tata Memorial Hospital, Mumbai. Before starting our session, I would like to request Fatima Shorna to show the poll questions, and all the participants are requested for poll voting. And at the end of the sessions, again the poll questions will be shown, and you all at the beginning and end you will also requested for poll voting. Shorna, please. As I apologize to you all, as because today is the Ramadan, they at the mid of the Ramadan, and the teachers, the high sir, he is sick, and he apologized me for not attending the session, and also the scientific secretary, probably he will attend at the last part of the session. Okay, Shauna, close the phone. Now, without losing any time, I would like to request our presenting medical college. Today, our presenting medical college is Sir Solimullah Medical College, and I request the doctor of Sir Solimullah Medical College to present your case. Dr. Rizwana, please.
Thank you, madam. Good evening. Am I audible and the slides are visible?
Yes.
Thank you, madam. Honorable foreign faculties, my respected teachers and learned audience, Assalamu alaikum. This is Dr. Rizwana Afreen, Assistant Registrar, Sir Solimullah Medical College, Mitford Hospital, Dhaka. I am going to present today's case. A 65 years old lady having menopause for 13 years, multiparas hypertensive, attended in outpatient department of Sir Solimullah Medical College, Mitford Hospital with the complaints of single episode of postmenopausal bleeding for 3 to 4 days. She had no history of postcoital bleeding, abdominal pain, pervaginal discharge, or taking any hormone therapy. Her bowel and bladder habit was normal. She has no family history of breast, ovarian, colon, and endometrial cancer. On examination, her BMI was 27. All vital signs were within normal limit. Breast examination revealed no abnormality. Accessible lymph nodes were not palpable, and abdominal examination was normal. On pelvic examination, vulva, vagina, and cervix were apparently looked healthy. Uterus was bulky, non-tender, mobile, and no adnexal pathology was identified. Investigation were advised, and her transvaginal ultrasonogram showed thickened endometrium about 9 mm. So, diagnostic endometrial curetage was performed, which revealed endometrial polyp represents high-grade serous carcinoma. Endometrial background was atrophic, and immunohistochemistry with P53 shows diffuse positivity more than 70% in anaplastic cells. MRI of whole abdomen revealed endometrial malignancy measuring about 30 into 20 mm with less than 50% myometrial invasion along posterior wall. Bulky uterus with focal adenomyosis on anterior wall and no lymphadenopathy or ascites. Now our plan is surgery. So what type of surgery will be appropriate for her?
How's sir, please?
Yeah, thank you. It was a good presentation. I would just, for the benefit of the student, I would just like to say that in a clinical examination, she should also include the status of the parametrium whenever you're talking about cervix or endometrium. So you mentioned adnexia free, just mentioned parametria also in word or free. Now, coming to the type of surgery, it'll again depend on one is the approach and second is the type of procedure to be done. The approach will depend upon the institutional protocols and the expertise and the facilities available, whether it could be minimally invasive or open surgery. The next question is whether you have a histological diagnosis of a clear cell carcinoma, you have an MRI showing a significant invasion. Now, the other question is whether you again, the facility and the protocol, whether your institution is doing any sentinel node dissections or they're not doing sentinel node. So I'll keep it open. I will just talk about a classical open surgery, what has to be done. So in this case, since it's the type 2 cancer, especially a clear cell cancer, I would go in for a type 1 extrafacial hysterectomy with bilateral salping oophorectomy, with omentectomy, with pelvic and para-aortic lymphadenectomy, and with the ascitic washings. Yeah.
Will you not go for the omentectomy in this case?
I said omentectomy. I included omentectomy.
Next.
The patient underwent laparotomy followed by extrafacial hysterectomy with bilateral salpingo-oophorectomy, infracolic omentectomy, bilateral pelvic lymphadenectomy on 2nd October 2019. On perioperative findings, uterus was normal in size. Both ovaries and fallopian tubes were apparently healthy lobe, no metastatic deposit identified. On CAT section, there was a polypoidal growth in the anterior wall of the uterus, which involved less than half of the myometrium. Tissue was sent for histopathological examination, and her histopathology report was high-grade serous carcinoma, confined to endometrium, and no omental or lymph node metastasis. So, MRI report showed myometrial invasion, but there was no myometrial invasion in final histopathology report. Should we go for review of the slide?
So why to, sorry. Why the slides? Definitely, the histopathology is more reliable than an imaging. So if the imaging, if the histopathology is saying there is no myometrial invasion, why should you doubt the histopathology over the MRI report?
Yeah, hi, Amita here. I agree with the Dr. Rupinder. You know, if it's by a surgical pathologist who has taken adequate sections, I think then no need. But if Santosh is there, maybe he can tell us how a surgical specimen should be processed and how many sections should be taken, how we do at TMH and other oncology center.
Still not done. We have the another pathologist.
Okay, so Santosh has now joined, yeah?
Not yet, yeah.
Okay, so, you know, if it is by a reasonable pathologist, I think there is no need. But, and you also need to see the number of sections taken. You know, many times they just take 1 or 2 sections. That may not be adequate because tumor may not be invading myometrium at places. So, you know, if grossing there was an issue, if there was problem with the histopathology slicing, then I think we should ask for a review. Otherwise, no. Between MRI and histopathology, as Dr. Rupinder said, we always believe in final histology, not on in MRI. On MRI.
Are you here?
And along with what Amita has, see, getting an MRI report, you need an expert. Sometimes that kind of expertise is not really available. CT scan is easily read. TVS is a very easy investigative procedure as an imaging procedure. But MRI definitely requires a certain amount of expertise. So sometimes we fault over there in our MRI interpretation. So we have to factor that in.
Right. So the other thing is, in most cases, we will do MRI after a endometrial biopsy or a DNC. So MRI cannot differentiate between a post-biopsy inflammation causing little, impression of myometrial invasion versus a true myometrial invasion. So that is another fallacy one may face while reporting on MRI.
Yeah, absolutely. I absolutely agree with that.
We have our histopathologist, Dr. Farida. Are you with us?
Yes.
Dr. Farida?
Ma'am, I'm here, listening to you.
Would you like to comment anything about this histopathology report?
I want to follow the previous speakers talking. In that case, that in our country, there is, from our perspective, regarding the grossing, it should be there, maybe some sort of mistakes will be there. So in that case, they may miss about the myometrial invasion. So from my point of view, I should definitely go for the review of the slide.
Yeah, and a review of the main specimen also, whether adequate and representative sections were taken.
Yeah, definitely.
Okay, next.
Ideally, how many slides should be prepared from the uterine specimen?
Farida, please. Farida.
For this sort of case, am I audible to you?
Yes, yes.
Okay. For the myometrial invasion, usually whenever we gross for a hysterectomy specimen, if there is any endometrial growth, at first we saw the gross specimen, what about the size of the tumor and how long the extent of the tumor involving the endometrial cavity. And we have to go further from fundus to up to lower uterine segment. We have to go for the serial section along with the up to perimetrium for observation of the whole thickness of the myometrial invasion. This is according to size of the specimen. If it is large one, in that case, the size of the slides and blocks will be larger, according to me.
The participants are requested to put your question on the chat box, please. Participants, please put your question on the chat box. Next.
These are just one question. These serial sections you mentioned, at what spacing or what interval you take normally? What is the distance between each?
Farida.
Could you please repeat the question again?
Serial sections which you take, I just wanted to know that you take more section from the area with the growth. What is the space gap between two sections? How many millimeters is the space between two sections?
Between two sections, 5 millimeter around.
Okay.
Usually thickness of the sections? What will be the thickness of this section?
Thickness will be as we are cut down by 3 to 4 millimeter.
Okay. Next.
And what will be subsequent adjuvant therapy?
So now this lady, it's stage 1A papillary serous, uterine papillary serous carcinoma, right?
Yes, yes.
Okay. So, at our center, we would give her adjuvant chemotherapy followed by Walt brachytherapy. She would receive, if she is medically fit, she would receive 4 to 6 courses of paclitaxel carboplatin followed by brachytherapy. That's the protocol we follow. Of course, I don't know whether there's good evidence to suggest this is the ideal one, whether chemotherapy is really required in early cases, but that's how we treat. Other important thing is, I think we need to know cytology report, especially in these kind of cases. So what was peritoneal washings?
Yes.
Were they negative? Was cytology negative, peritoneal washing?
Peritoneal washing didn't done.
It wasn't done. Okay. And we also have not addressed, I think, para-aortic lymph nodes because only bilateral pelvic nodes were addressed.
Yes.
So we would give her chemo, paclitaxel, 4 to 6 cycles, depends how she tolerates, followed by brachytherapy.
Yes, I would also second that. The only situation where I would withhold chemotherapy is that when we have an initial diagnosis of papillary serous carcinoma or focus of it, and it comes out with DNC and the final histology doesn't show any residual tumor, or it could be in the surface of a small polyp. So those are questionable cases. If the peritoneal cytology negative and there, you may just get away with brachytherapy. But otherwise, all cases of clear cell carcinoma would need adjuvant chemotherapy. I would think of pelvic radiation only if there is extensive LVSI or there is a lymph node involvement, pelvic lymph node involvement. Otherwise, brachytherapy and chemotherapy, as Dr. Amita said, should be good.
So the other thing is in histoplasmin, I think there was no mention on LVI and perineural invasion. Those two are extremely important in cases of endometrial cancer in deciding the adjuvant treatment as well as prognosis.
Yeah, but the good thing is that in the histopathology, they did P53, which was mutant. So all high-grade serous, early stage 1A included in that. If they are P53 mutant, they are high risk. And based on the molecular analysis of POTEC3 trial, it has been shown that these patients will benefit from adjuvant chemotherapy. And Dr. Amita has already explained in detail that this is the reason why we'll give chemotherapy in this patient in spite of being her in stage 1A.
What advantage will we get if the patients in these patients do the peritoneal cytology? If they
so whether we do the cytology, I mean, what's the question, Dr. Shana?
Yes.
So the thing is, cytology independently may not change your treatment plan, but it has shown to be a poor prognosis indicator of overall poor prognosis, and in association with other prognostic factors. If cytology is also positive, it indicates poor prognosis overall. Although, it's controversial, the value of only cytology positive, but it is often associated with other poor prognostic factors. And if cytology is positive, then our experience is that these patients, they have, although early disease, but their outcome may not be same as other cytology negative early cases. But this patient, regardless, our protocol is to give adjuvant chemotherapy, cytology negative or positive. But I think it's better to have a cytology, because for further analysis, in case you want to look at your cases, it's important to have complete information available on histopathology as well as cytology.
I think Dr. Charco can tell us about the cycles of chemotherapy, especially if you are going to plan brachytherapy. Can brachytherapy be planned in between if you're planning 6 courses, or if it is less, then obviously it can be done after. So what is the usual thing you would advise? 4 cycles, 6 cycles, and how to adjust the brachytherapy?
For a patient like this, I would say, 4 cycles should be enough. You could give, depending on, how well she's recovered post-op and how quickly you can give the brachytherapy, you could give the brachytherapy and then we could give the chemotherapy, or we could do it the other way around as well. So I don't think the way we give it would really matter. In the trials, I think they gave brachy first and then they give the chemotherapy. Yeah, so 4 to 6, 4 cycles would be enough in this patient, and then, just follow up would be good, and we should, have a good prognosis here.
What is the message from Dr. Supriya Chopra ma'am for the participants, this type of case, the serous adenocarcinoma, endometrial carcinoma, serous type, in these cases, what should be the first adjuvant treatment? Chemotherapy, then brachytherapy, or brachytherapy, or then chemotherapy? What will be the message? Dr. Supriya Chopra. We are talking.
So Ishra, I don't know if Supriya is there or not, but we generally, I think Seema will agree, we generally give chemotherapy first and then brachy.
Yes, we give chemotherapy first, followed by brachytherapy, or if pelvic artery, whatever is required. Because
yeah.
Yes, ma'am, please go ahead.
No, please continue.
Yeah, so the reason being that why we give chemotherapy first, followed by RT, because even we believe that this is specifically true for patients who receive pelvic RT, that after receiving pelvic RT, their tolerance to chemotherapy reduces significantly. And even in the trial setting, close to 30% of the patients, they could not complete the 4 cycles of chemotherapy, which was planned after radiation.
Yeah, so 2 additional points for sake of academic discussion, I would like to make. One is, if possible, we should do BRCA testing in uterine papillary serous carcinoma, especially if there is a family history in this patient. I think there's nothing significant. And the other thing is IHC for HER2. So these 2 are, I think, additional things we may consider, especially, some, I think 15 to 20% patients may show, may have, HER2 positive and they relapse, not at this point, but, trastuzumab may be one of the options for these patients. Seema, would you like to, or Dr. Chacko, would you like to?
Yeah, I would agree. I mean that an IHC would certainly help us to add trastuzumab, but usually not in 1A disease. In something more advanced, I would advise trastuzumab in addition to the chemotherapy.
Right. So generally we use in metastatic or recurrent setting if they are HER2 positive. Not, of course, not in this patient. But not at this point, at least not as part of our first line treatment.
Can I just add one thing? See, since it is a serious histopathology, we always give 6 cycles in our institute. We don't, even though the stage is of course stage 1A only, but here the grade is higher, so the grade will determine our line of treatment rather than the stage. So having said that, what I would say that we would give 6 cycles of chemotherapy and we would follow it by brachy instead of the brachy first and the chemotherapy later. And even if we have just this much of IHC, which says this is P53, that in itself, the expression of P53 and the histopathology is by and large basic enough to determine our line of adjuvant therapy.
But what would be the benefit of giving 6 cycles over 4 cycles?
The standard of care is 6 cycles, no? And why would you want to, no, but what is the rationale of giving 4 cycles?
See, because even in majority of the trials which have included endometrial cancer, beginning from the Mango LED trial and the PORTEC trial, they've used 4 cycles.
Yes. Although I think their protocols were somewhat different, and of course, it's not just 4 cycles; they gave concurrent also.
Yeah, I mean the chemotherapy, paclicarbo was 4 cycles.
In the
along with concurrent chemotherapy, they give cisplatin.
Yeah.
No, the whole planning and those PORTEC trials was different.
So I think the fact is we really don't know the right answer. 3 cycles, 4, 6, but I think there's no trial in uterine papillary serous carcinoma early stage where 4 versus 6 have been compared. But that's how we have been practicing, right?
Yeah.
I have one.
Not only that, it's not. I don't think a trial would be really feasible because you can, as on today, we can neither justify the 4 cycles nor justify the 6 cycles. So I'm not very sure that we can actually do a RCT on this.
No, we cannot, and I think
I have one point. I'm in a comment. You could ponder on that. Is there a point in differentiating serous carcinomas which infiltrate the myometrium and which do not infiltrate the myometrium? The systemic metastasis chances are more when there's infiltration of the myometrium, LVSI. If it is limited to the endometrium, can we get away with smaller, like we had with ovarian cancer, early ovarian cancer versus didn't show difference? Whether serous carcinoma limited to the endometrium, would there be a place for lesser duration of lesser cycles of chemotherapy?
Yeah, that's a very good point, Dr. Ahuja. But the thing is that are we going to determine the treatment in terms of the myometrial invasion or the LVSI? Where we do not have an
LVSI, there is no doubt you give.
So
I'm saying both should not be.
So where we do not have an LVSI report, regardless of whether there's myometrial invasion, regardless of the fact that there is no myometrial invasion, I still think we should err on the side of more rather than less.
Because my reason was because some of the guidelines say observation versus chemo. I am in favor of chemo, but then again, my doubt is only whether limited to endometrium, we may get away with 4 cycles. That's the thing.
Yeah, I agree with you, Dr. Ahuja. And there are some reports suggesting if it is uterine papillary serous in a polyp, they actually do not recommend upfront chemotherapy. Keep it reserved for recurrence and just give radiation. So, but because of rarity of uterine papillary serous carcinomas, we don't have a really huge patient experience. And, whatever we have is mostly retrospective studies. So, really don't answer.
Yeah, Amata, in that you're right. There are definitely reports which say that where the serous papillary report has come only in a polyp, we can let the patient be. In fact, just put an observation and no adjuvant treatment. But like you said, of course, few reports.
Right.
Yeah, so
let's see what
the difference between 4 and 6 cycles of chemotherapy is basically the adverse events related to chemotherapy. Okay, and the adverse events that are of concern is the neuropathy. So, between 4 and 6 cycles of chemotherapy, I would say the neuropathy would be, kind of the breaking point for many patients. And, they have to often live with this neuropathy lifelong afterwards, which is a concern. So giving the least amount of chemotherapy, if it gives the same benefit, and from the evidence that we have, it looks like, 4 cycles is almost the same as 6 cycles. Although, I like was already mentioned, there's been no head-to-head trial which looked at this question specifically.
This patient was like that.
What was done to her, yeah. So
this patient has also atrophic endometrium, and this malignancy was seen in a polyp. As you shown, her slide showed that there is endometrium was atrophic. Dr. Rizwana, go to our previous slide. Histopathology report first before surgery. Previous slide, previous.
Here's the histopathology report, ma'am.
No, first histopathology before surgery. There is the atrophic endometrium. Yeah.
Yes.
Yeah. Endometrial polyp harboring the malignant tumor. Here the malignancy, the endometrium was atrophic, and there's a polyp, the malignancy was there. So
yeah, but if you right, it looks biologically aggressive, more than 60%.
So the point is that after the polyp was removed, the residual tumor in the uterus is still there. So we cannot say it's only in the polyp.
Yeah, that's right.
Yes.
And the fact that there's a background of atrophic endometrium in fact makes it more aggressive than if there was a cystic hyperplasia or adenomatous hyperplasia.
I am Professor Sadara Khatun. I want to say something about atrophic endometrium.
Yes, ma'am.
You know that most of the serous carcinomas, high-grade serous carcinomas in the endometrium arises from the atrophic endometrium. So it is associated condition, atrophic endometrium and serous carcinoma.
Already announced this dance kora lagbe. আর কত শুনে না
প্লিজ মিউট হন ম্যাডাম
so atrophic endometrium is not any does not show any significance because atrophic endometrium is usually associated with serous carcinoma of the endometrium. It's associated condition most of the cases.
Swarna, are you here?
আরে উনি বিল্ডিং করতেছে না
Swarna. Swarna. Okay, ma'am. Somebody is talking, so I want Swarna to mute her. Yeah. I have a question to Santosh Menon, sir. Santosh Menon, sir, he has joined. There is here the immunohistochemistry only P53 was done. In this type of cases, what other do you like to do for these patients? Only P53 is enough?
Yeah, good evening, everyone. I think most of the times the diagnosis is pretty much based on morphological pattern and the diffuse P53. We all P16 to the armamentary. Usually these are P16 diffusely positive. Having said that, very high-grade endometrial carcinoma can also be P16 positive. So most of the times, when we are debating between endometrium versus serous cancers, it's most of the time we fall back on morphology many times. Obviously, P53 has to be positive. It has to be mutated.
Do you not do MMR?
Not in all cases. No.
Okay.
MMR may be positive. MMR may be high, even endometrial. Serous does not necessarily show MMR high.
Thank you, sir.
But does P53 give any additional prognostic or therapeutic indication in a papillary serous carcinoma? Because our management is going to be the same. On the contrary, I feel if it is a clear cell carcinoma, there a P53 would be useful because some clear cells have a P53 and they can be offered chemotherapy.
Yes, sir. I would tend to agree. I think SEMA would be in a better position to comment on that. But yeah, many clear cells may not be P53 positive actually. So P53 basically tells you whether it's a high grade, really high grade tumor. When you're really contemplating between a grade 2, grade 3, sometimes 53 diffuse will help in picking up a serous cancer should be mutated for P53 generally. So that's the most important marker in serous.
Okay, thank you, sir. Is there anybody who want to like to comment? Dr. Amita ma'am or Rupender ma'am or anybody or Ahuja sir? If not, then we'll
I would just like to say that if I would have been involved in the surgery, I would have done a para-aortic node dissection also because this is an aggressive histology. We still do not know the therapeutic benefit. We do not know that it is not beneficial. There is no proof either way. So in such aggressive histologies, I would do a complete pelvic and a para-aortic dissection.
If these patients, like these patients, Amita Maheshwari and Rupender ma'am, if these patients, they attend in your hospital with only simple hysterectomy with bilateral surfing oophorectomy, do you go for the staging laparotomy?
That's a very difficult question to answer, So what we do at our center, let me tell you. So first of all, a detailed review of intraoperative findings, histopathology report, and preoperative imaging, followed by a detailed discussion with patient and relatives. So many times, and actually often our patients refuse another surgery. Having said that, if there is no disease seen on post-operative imaging, we generally end up giving only adjuvant treatment. We treat them a little more aggressively in terms of adjuvant treatment. Most our patients do not agree for second surgery. So that is the situation at our place.
We also face this. As far as we are concerned, by and large, it is the same. Some patients, we do offer them surgery, a kind of a staging laparotomy. And that also, if they come to us within first 4 weeks of the surgery, many times they come to us pretty late. So the question of a resurgery then, in any case, is not there. So we have to offer them adjuvant therapy, and we are a little more aggressive in the adjuvant therapy in that case. We do imaging. Only thing is that post-operatively, you might find enlarged, say, lymph nodes or something which might not have been there pre-operatively. And then it becomes a little difficult to decide whether, are these just reactive or inflammatory or probably not disease. So these kind of dilemmas we do face. Otherwise, I think the patient does well enough if they are offered proper adjuvant therapy. Because if we are going to do surgery and it in a way it delays the adjuvant therapy even more, especially if they have come late to us. So perhaps it's a little wiser to offer them adjuvant therapy rather than surgery. Though we we have done surgery in a few of such patients when they've come to us, say within a couple of weeks or of the first surgery. Because see, if the patient is coming from far or from a remote center, by the time they get the histopathology report, it is already 2 to 3 weeks have passed. And when they go to their primary physician, and then they're advised, and then they have to travel and all of that. So that adds to the delay of the patient reporting. And then of course, and we do insist that they should try and get the blocks as well, because they might not have been given the best of the slides. So getting the blocks really helps. So even if it means a little bit of delay, we do tell them that please get the blocks as well. And because that's how our pathologist wants it.
The same scenario here, the patients comes with just like this report, and we always advise the patients about then they advise the details and we offer for the staging laparotomy, and maximum patients, they don't agree with this staging second time surgery. In that cases, we do the imaging, and after that we give the aggressive treatment. Sabra madam, what is your opinion?
My opinion is that this is a high-grade serous carcinoma. That is, the behavior of this cancer is like the serous carcinoma of the ovary. So if this type of patient come with the history of simple hysterectomy, this patient should have the laparotomy. Ideally, she should have the laparotomy and omentectomy, bilateral pelvic lymphadenectomy, aortic lymphadenectomy, and also this type of histology should have the multiple biopsy taking for staging. We should counsel the patient. In this regard, I would say that these patients with incomplete surgery should counsel them very clearly. And I think many patients will not agree, but some of the patients will agree to have the definitive surgery. I think some of the patients agree. And regarding the sample, this patient had not any biopsy taking, as the parabolic butter and the vesicular pulse and the other side, multiple biopsy taking, that is staging. This was not done in this patient, as this type of histopathology should have the correct staging. And another comment is that many of the time, this type of histopathology, even in this type of histopathology, many of the time, they without any myometrial involvement, many times this patients are kept in observation in our country. I think considering the scarcity of radiotherapy facility, many times these patients are kept in observation only when there is no biochemical improvement in final histopathology. So I think my opinion is that with this type of histopathology, that is high-grade serous carcinoma, should not keep observation or surveillance only, should always have some adjuvant therapy. My opinion is.
Okay. Thank you, madam. Rizwana, please. Any other question?
No, ma'am.
Dr.
Thank you all my respected teachers for enlightening us with your valuable guidance.
Thank you, Dr. Rizwana. And
thank you all for sharing.
Regarding this case, there is a question in chat box as periodic lymph node sampling not done. Is there any role of PET-CT before treatment? Is there any role of PET-CT before treatment? Dr. Seema Gulia or Raju Chaku sir?
We wouldn't do a PET-CT in these patients. Yeah, I mean, unless there was some clinical evidence that there was disease that is spread over that changes the stage totally. So typically, we wouldn't do a PET in these patients.
Yeah, I agree with Dr. Chaku. We also won't do PET in this case. So.
Yeah, absolutely. In fact, a PET can be quite misleading.
Right. Yes, immediate post-op PET cannot differentiate. And it may pick up some non-specific things. So I don't think we would do PET-CT.
Yeah, that's true.
Another question is there. Do at baseline and at follow-up like ovarian CA-125.
No, that is my reply to the question. Someone asked, can CA-125 be used? So I said yes, in serous endometrial cancer, CA-125 can be used. And if you have done at baseline and follow-up, I mean, it is same as in serous ovarian cancer.
Yes, yeah, absolutely.
Now, Dr. Rizwana, please. Yes, ma'am.
No, appendix, there was a question whether appendectomy should be done. So answer is no. Routine removal of a normal looking appendix is not recommended in uterine papillary serous.
Okay. Yeah, appendix has a role only if there is a mucinous histopathology. So if you have a mucinous histopathology, then perhaps one might want to remove a normal looking appendix. But otherwise, I agree with Dr. Amita completely. We do not need to remove the appendix at all.
So Rizwana, please stop your screen sharing. And now she has because all the medical colleges, they are treating the COVID patients. So they have the only one patient. So we have other patients to discuss in these sessions. And our next presenter is Dr. Shushmita Sarkar. Dr. Shushmita Sarkar. Shushmita, please. Shushmita Sarkar. Are you here?
Yes, ma'am.
Yes, please. Before that, there is another question. Is there any evidence to give adjuvant EBRT in a state of second surgery? Dr. Asma Siddiqa. It's a hard question. In this endometrial cancer, because this is the only one case of endometrial malignancy, then other cases are the ovarian cancer. So I would like to stop these questions here.
Yeah, so I think what we just discussed, suppose a patient is stage 1B, grade 2, where if comprehensive surgical staging was done, we would have just given out grade 3, only brachytherapy, but only if surgery was incomplete, nodes were not addressed. Then in that scenario, we may give EBRT and instead of brachy alone, instead of removing lymph nodes. So yes, it was only simple hysterectomy and salpingo-oophorectomy. And if there is a substantial risk of lymph node metastasis, as in if there is deep myometrial invasion or grade 3 tumor, if we are not removing lymph nodes, we can, we do EBRT in these cases.
Dr. Shahana, can you hear me? I got disconnected. Can you hear me?
Yes, ma'am.
Just I have two basic questions regarding the first case to any one of our foreign faculties can answer. Just the first question is, do you suggest to do P53 or other molecular marker in endometrial curettings, or you prefer to do it in final histopathology? This is one. And another question is, as this is a high-grade serous cancer, during pre-op evaluation, do you suggest to do CT scan?
I'll take the first question. Regarding the immunohistochemistry, the ideal would be to do it in the surgical specimen. But then sometimes what happens, the surgical specimen may not contain enough tumor because of the earlier DNC. Then we could revisit the DNC slides and do the immunohistochemistry there.
So, Dr. Ahuja, I would slightly differ, and if Santosh is there, he can correct me. We would prefer doing it on, often we do on DNC specimen. One, it may help in our decision making.
Yes.
Like, if we get P53, then we would be more aggressive during surgery. Yes. So I think our preference is, if DNC tissue is adequate, we do on endometrial biopsy tissue, and we do not repeat it on main specimen if histologically we don't see anything different.
Right.
Am I right, Santosh?
Yeah, I agree with you, Dr. Amita. We really put in a lot of effort in delineating a serous from endometrioid on a curettage itself, because it can help in decision making during surgery, as well as to plan the adjuvant also. So we really put in a lot of effort to try and delineate as much as possible high-grade serous from endometrioid on a curettage specimen.
Yes, we agree with Amita Maheshwari.
Yeah, we also do the same, because we try to do at least a P53, if not more, on the curettings itself, because that straight away kind of differentiates between the endometrioid and the serous, and definitely your the surgical planning depends a lot on that.
And our general policy is not to repeat same IHC markers on main specimen. We do not repeat them then, if it's done. Unless, of course, some new, type, like if you see clear cell or some other tissue which was not seen on DNC, then only we do. Otherwise, we don't do.
Yeah, same. Likewise for us also.
Yes. Thank you, ma'am. Now we'll go for
and no, there was one more question, right?
Regarding CT.
Right. So it depends what is available. We generally, if patient can afford, we do MRI pelvis and CT abdomen, or at times we do MRI pelvis and screening of MRI of abdomen as well. Or we can just do MRI, a CT scan abdomen pelvis. So everything is fine. And generally, for early cases, we do not do CT thorax. We just limit to abdomen. Not every patient undergoes thorax CT.
Due to high grade, if a patient has already done a MRI, due to high grade carcinoma, you don't suggest to do CT.
CT of thorax or abdomen, we do. Screening of abdomen we would do, but not chest. Chest CT we do not do for every patient. We do X-ray only if if you see ovarian mets, or if there are lymph nodes, or if it's advanced disease, then only we do a CT thorax. That's our policy.
Okay.
Yeah, same here. These days, of course, we are doing the CT test. That's more for the COVID.
Picking up COVID, asymptomatic COVID.
But otherwise, we just limit ourselves to a chest X-ray and a CT upper abdomen and a MRI pelvis.
Right. So CT thorax only if there are para-aortic nodes, or if there is disease which suggests abdominal spread, then we do, or if any abnormality seen on X-ray chest.
And actually, if you think the carcinoma is early enough, sometimes we don't even do a CT of the upper abdomen. We just do an ultrasound.
Right. That's also good enough. Screening ultrasound.
Yeah, that's good.
Okay, thank you, ma'am. All the participants are requested to put their questions on the chat box. And next presenter our is Dr. Shushmita Sarkar. Shushmita Sarkar, please go through.
Madam, am I audible and visible?
Yes, you are.
So good evening to respected overseas faculties and teachers of all disciplines and my colleagues. I am Dr. Shushmita from National Institute of Cancer Research and Hospital. So she is 18 years and unmarried. She was admitted in an emergency unit of a tertiary medical college with severe abdominal pain and a pelvic mass. On ultrasound, there was a right adnexal mass. She was then underwent a laparotomy followed by removal of right-sided ovarian mass on August 2018. Her histopathology report was fibrosarcoma of right ovarian tissue, but she couldn't come due to financial issue. After 1 year, she came to our hospital with huge abdominopelvic mass. On general examination, she was cachexia, ECOG was 1, no accessible palpable lymphadenopathy, and vitals were within normal limit. Parabdominally, a huge abdominopelvic mass around 20 into 18 cm with irregular surface and ill-defined margin, and parectally, the mass was higher. So CT scan of whole abdomen revealed a fairly large mass of mixed attenuation, about 16.5 into 16 cm in abdominopelvic cavity, more on right side, anteriorly the mass abutting the parietal wall, and inferiorly the mass indents the urinary bladder. Sorry. Regarding her tumor markers, CA125 was only raised and it was 332 unit per ml, and chest X-ray was normal. We have reviewed her slide and it came as compatible with sclerosing stromal tumor. So in her first histopathology report, it was fibrosarcoma of ovary, and in her reviewed slide, it is sclerosing stromal tumor. How to settle this controversy? Ahuja sir.
Santosh Menon sir.
Refer to Dr. Santosh Menon
to
settle the controversy.
Dr. Amita, this is difficult because one says fibrosarcoma, the other I read somewhere it is endometrial stromal sarcoma. The third one, which is sclerosing stromal tumor. So sclerosing stromal tumor is a completely benign tumor. It has a very characteristic morphology with edematous areas, spindle and vessels, which are very characteristically arranged within the stroma of ovary. So I think this controversy can only be sorted out if I happen to see the slide, because fibrosarcoma is a high-grade malignancy. The other very, very important thing I want to tell the audience is that when you see a spindle tumor in the abdomen, which is somewhere close to the rectum and close to the gut and all, we definitely need to run a battery to rule out a GIST first. That is the first marker I generally put in any spindle tumor. And most of the times when you don't know where it is arising from, it turns out to be a gastrointestinal stromal tumor, which has got a completely different therapeutic lineage of treating with imatinib. So last week also we have diagnosed one case of GIST, which came as an adnexal mass with liver met, and that came out to be GIST. So I think this controversy can be sorted out only if I get to see the slide, because ES has got a characteristic morphology which is totally different from sclerosing stromal tumor.
So
and when
it's
we have
unlikely to be sclerosing because it has recurred. So that's sclerosing is a very benign tumor. It should have
stromal
recurred.
tumor is a totally benign tumor. So I think I don't know whether the initial one was a biopsy or whether it was a resection. I don't know. Because a biopsy, all spindle tumors can look alike, and we need a battery of IHC to differentiate on. But when we have a resected specimen at hand, we are in better position to see the whole tumor with circumscription and all those mitosis, necrosis to exactly diagnose the tumor.
Yeah, whatever it is, it's definitely very, very aggressive. One would want to put their money on sarcoma rather than anything else.
Yes, I agree, Dr. Rupinder. I think it looks like an aggressive sarcoma. In a young 18-year-old, I would really think that this sarcoma might be arising on a background of Sertoli latex. Because Sertoli latex have a very high sarcomatous rate of changing into sarcomas, and they present like this in young people.
Yeah.
Quite a few of them.
Have you done inhibin or another stroma?
I think the question now, I think, was how to proceed was basically she's presented with a mass. Now we have to see whether we can offer any surgical solution, or we cannot. The surgery will help in relieving the symptoms as well as giving her the diagnosis. So whether she's suitable for surgery or not, we have to complete the imaging and see. So if there is, as far as the imaging goes, there's no visceral metastasis in the liver. I think I'm not too sure about the lungs. Retroperitoneum, the vessels and all are okay. So there's no infiltration into the parietes. I was not too sure about the film. So if there are no contraindications to surgery, if the general condition is okay, then we'll go in and see if we can resect the tumor, because any sarcoma, nothing else will help unless you can resect the tumor completely. And that will give us all the answers.
Sushmita.
Yes, agree with Dr. Ahuja.
So she underwent laparotomy on 26th August 2019 in our hospital.
Only thing is, sorry to interfere, sorry to interrupt. Only thing is that if it is not resectable, which of course a proper imaging would tell us, then perhaps we might have to resort to neoadjuvant chemotherapy. That again becomes a controversy.
Previous slide. Next.
So she underwent laparotomy on 26th August 2019 in our hospital. Her preoperative findings were hemorrhagic peritoneal fluid, fungating fragile ovarian mass on the right side, and capsule founder disrupted. Deposits on the parietal wall, bladder wall, and gut wall. Left-sided ovary was apparently healthy. So right-sided salpingoophorectomy with omentectomy and removal of all metastatic deposit was done. So her histopathology report was low-grade endometrial stromal sarcoma on right ovarian tumor and metastatic endometrial stromal sarcoma on omental tissue. Now, how to manage her?
The initial surgery, what was done? Was one ovary removed, or what was it, the first surgery? So now she has one ovary remaining, or there's no ovary?
In her first surgery, only ovarian mass, admixal mass removed, not the ovary.
So one ovary is there?
Right ovary. Right ovary is there.
Okay, so I think I have a question. If you have frozen section facility, with the frozen, would have helped you in deciding.
We have kept frozen facility. Frozen section was our plan, but on laparotomy, the picture was so devastating, and on naked eye, it looked metastatic. So
no, so we still have left her uterus and other adnexa in situ, right?
Yes,
so the question is, other thing is we need to have ER/PR on the tissue, because majority low grade ESS are ER/PR positive, receptor positive. So was ER/PR done?
No,
and also important to know.
We have advised to see the hormone receptors and immunohistochemistry, but she couldn't do this.
Okay. The other thing is, I don't know whether proliferation markers were done.
No, ma'am.
Amita madam, the image did not look like a low-grade ES system. Yes. I saw just one image.
Where did you see? I didn't see any image.
I saw one slide. I just saw a fleeting glance of one image.
Okay, I missed it.
I don't think I can rule out a high-grade sarcoma to this. I saw one image, yeah.
Both the slide.
Yeah, the behavior is not that of a low-grade ESS.
The behavior is also not like a low-grade. Low-grade ESS usually come after many years.
Okay, so this is the one.
Yes.
Yeah, I just saw this. I don't think this is typical morphology of a low-grade. It's got myxoid areas and it's got cells which are packed up, and they show a lot of pleomorphism as far as I'm concerned. So I would really start thinking of probably to rule out a sarcomatous sertoli or a high-grade sarcoma in this person, because the clinical presentation and the images don't match up to a low-grade ESS. I think that's of utmost importance to get the slide review, because a low-grade ESS versus a high-grade sarcoma, the management and the prognosis is completely different.
Yeah, it may be actually one of those Sexford stromal aggressive patient, So.
Here also, expertise in pathology, oncopathology is so required, because even sometimes for the best of us, we fault in the diagnosis and it becomes difficult.
But the rule of thumb is whenever the clinical presentation is not matching with the histological picture, we should always ask for review of histopathological slide.
Absolutely, slides and blocks.
Yes, all these are, and I have a comment here. The patient is so poor that everything was done from our fund. They didn't spend a single coin. Yeah.
Shahanaz.
Yes, ma'am.
Shahanaz, this patient, behavior of the tumor is behavior is like high-grade tumor and highly aggressive type of tumor, sarcoma-like behavior. And the histopathology report is 3 times. The histopathology report is different types. I think final treatment should be done. The patient should be considered as a high-grade tumor, an aggressive type of tumor, sarcoma-like sarcoma. So, question is whether the ovary, right ovary, and the uterus is kept in situ. And then my question is, what is the situation of the patient just now? Is she alive?
Yes, madam.
She had adjuvant treatment.
Now we'll go for we are going, madam, we are going. She was advised for immunohistochemistry, everything, but when we advise anything, the patient lost. And again, she come back with recurrence. And Shushmita, please continue.
So our tumor board decision was immunohistochemistry, hormone receptors, and followed by adjuvant therapy. But this non-compliant patient denied all, and she was lost to follow-up. 9 months, after 9 months, she presented with an inoperable pelvic mass. According to tumor board decision, she received 6 cycles chemotherapy with paclitaxel, ifosfamide, and mesna from June to December 2020. 3 months after completion of chemotherapy, she reported with a huge abdominopelvic mass. On general examination, she was moderately anemic, cachexia, and no palpable lymphadenopathy. Parabdominally, moderate ascites was present and a huge abdominopelvic fixed mass about 22 into 25 cm with firm consistency. Parectally, the mass was high up. A CT scan of the whole abdomen said complex
Smita? Is she disconnected, Shushmita?
Sorry, ma'am, I was disconnected. CT scan of whole abdomen revealed complex pelvic mass about 15 into 14 into 10 cm with internal segmentation of pelvic cavity with peritoneal nodules and huge ascites with right-sided moderate pleural effusion. So we have done CT chest and it revealed right-sided massive pleural effusion with right-sided pulmonary consolidation, but no hilar or mediastinal lymphadenopathy. CA-125 was 278. So what would be her further management plan?
I think it would be best supportive care.
Palliative care.
Yeah, absolutely. Because if she's not going to take any treatment and she's not going to get any tests done and all of that, very little we can do. Very little we can even discuss actually.
She should have palliative care.
Raju, do you have any comment? Raju Chakur sir or Seema Gudia ma'am?
I mean, I kind of agree. In the first place, you don't really know what this tumor is.
Yes.
So that would be very important to know. But beyond that, I really wouldn't offer her anything because, assuming that this is a high-grade sarcoma, we've got a recurrence post-surgery, which is inoperable. We're really not going to, give her any benefit by adding any cytotoxic chemotherapy to her. Although, one comment that I'd like to make is, today, with most of the sarcomas, one of the things that people are doing is looking at molecular markers, like, for example, whether they have fusion molecules there. And that might lend to certain therapies which could have quite, dramatic benefits. But, that's just more for an academic discussion than for anything to do with this particular patient, palliative care.
Yeah, I agree with Dr. Chacko that for this patient, definitely she is so she's not compliant to treatment at all. So there's no point in referring her any other therapy. But just for the students, I would like to make a point that whenever we are suspecting sarcoma, and if sarcoma is the diagnosis, then adriamycin-based therapy is the chemotherapy of choice. And for her, definitely she should be referred to palliative care, and we should relieve her pleural effusion. That will give her only symptomatic benefit.
Sushmita.
So, is there any role of hormone therapy or RT, radiotherapy?
No role of hormone therapy because the clinical behavior is consistent with high-grade disease. Even if there is no further review of pathology slides and block if possible, there is no role of hormone therapy. RT also, I don't think there is any role of therapy in such extensive disease.
Yeah, I think this patient is for best supportive care. So palliation of symptom, that should be the aim now.
Next.
Shahana, I'm leaving. Shahana.
Okay, madam. Okay, thank you, madam. Thank you for your journey.
Thank you. Amita Maheshwari, you are coming on 8th.
Yes, ma'am. 8th. Yes.
Welcome. Thank you. I'm leaving.
Thank you. Thank you.
Thank you.
Good night.
Thank you.
Good night.
Sushmita, next.
We have done core biopsy of the mass, and it came as low-grade endometrial stromal sarcoma. So our tumor board decision was palliative chemotherapy with gemcitabine.
Santosh Milan, sir, what should be the final histopathology? Sir, are you here?
No, I think we don't see him. Yes.
Yes. So next, Sushmita, next. So histopathology report is the main dilemma here, I think so.
Ma'am, Farida ma'am is here.
Yeah, Farida. Farida.
Yes, ma'am.
Yes.
I have to point out some issues. As I review the case, it started from the, so far I recall, from 2018. Is it? Yeah. 19. So firstly, the patient presented with the abdominal pelvic mass that was reported as fibrosarcoma on 2018. Then after it was reviewed, giving with a diagnosis of sclerosing stromal tumor, which was a benign case. And after that, in 2019, again, she was reoperated with abdominal pelvic mass. Then after we did, it was reported in NICRH. We have given so many blocks, and from that, we don't get any sort of necrosis. Though the tumor we saw on histopathologically, microscopic examination, it was very cellular, but I don't get any that much evidence of atypical mitosis or increase in the number of mitosis. So we have to diagnosed the case as endometrial stromal sarcoma, low grade. Okay, at that time, we have also advised for an immuno just to confirm the diagnosis. So this time, say 1 week back, Professor Shahana, madam, and her team again, they did a guided core biopsy from the abdominal mass. The slides that are pictures given, it was slides just two days back. So here we got 3 or 4 cores, and here is the tumor mass, some clusters of tumor cells, though it looks, I don't know, in image, it looks very aggressive, but I have shown the slides to Dr. Shushmita. This time I didn't get any mitosis again.
Probably it may be due to cancer.
So my opinion is to go for, again, immunohistochemistry. And another question to the faculties, say gynecology and abroad faculties, if it is a high grade one, so how these patients survive still now for the last 3 years?
No, it's not necessary all high grade will not survive. High grade, the clinical behavior has been like high grade in the sense that she has continuously progressive disease. So we cannot say that the clinical behavior is not like a high grade.
I see.
You know, just because she has survived for so long, you cannot say that it is not a high grade tumor. High grade and low grade is not dependent on survival. No? Many times we find that when an ESS recurs, it then recurs of the high grade tumor. So I'm not sure what exactly is the histopathology. Santosh would be in a better position to answer. But whatever it is definitely an aggressive tumor.
One point to note, I want to review this case with the immunohistochemistry. On the following session, I would like to give a feedback. What was the tumor regarding the IHC?
Okay, right. I think we would also be interested in knowing her immunohistochemistry.
Yeah, that would be nice.
Thank you.
Yes, thank you. Sushmita?
My question is to Farida ma'am. Ma'am.
Yeah.
Endometrial stromal sarcoma of ovary. Can histopathologically it mimics sex stromal tumor?
Morphologically a bit. In few ways, in few histomorphologic areas. Not totally along with that, but it is, if you got the whole tumors, not in that so many sections, some areas may mimic like sclerosing stromal tumor. But between these two, there is the tool, IHC, that can confirm between these two.
Okay. Sushmita, what other question?
So tumor board decision was palliative chemotherapy with gemcitabine. So is that okay?
First of all, we have to confirm the diagnosis. Then only we can decide on what type of chemotherapy. Even if she is high, we consider for the time being that she is high-grade sarcoma. Gemcitabine alone is not a good choice because we do not see significant, any response with single-agent gemcitabine.
What did she receive before?
Before she received Pecli and ifosfamide. So if it is high-grade sarcoma, my choice would be single-agent adriamycin.
Yeah, she has not got adriamycin.
Next, Sushmita.
So, ma'am, some things to be sorted out. So I think we are looking forward to IHC, and I want to stop here. Thanks all for hearing.
Thank you.
Dr. Shushmita, for your nice case. Now we'll go for the third case. Can we go? Third case. The faculties, please. Dr. Dilruba.
Yeah, sure. Yeah, sure we can. Only I'll have to leave in about 10 minutes. There's something come up. But shall we listen to the third case?
Okay, ma'am. Dr. Dilru, our scientific secretary, Dr. Kamaluddin, probably Dr. Kamaluddin Bhai is joined with us. Kamaluddin Bhai, please. Kamal Bhai. Dilruba, you please present your case. Somebody had question here, what could be best? Can we give letrozole as in uterine low-grade stromal sarcoma? Another question, immunohistochemistry panel, what markers include?
So we can give letrozole, but in this patient, we need to confirm her receptor status on immunohistochemistry if she is receptor positive, but because her one ovary is in C2, we need to give, if you want to give letrozole, we will give Lupride or GnRH along with letrozole. So she's a premenopausal lady, so we can't give letrozole alone. We have to cause medical castration and letrozole.
Yes, thank you. Dilruba, please.
Thank you, ma'am. Assalamu alaikum and very good evening, honorable foreign faculties and learned audience. I, Dr. Dilruba Yasmin from National Institute of Cancer Research and Hospital, Mohakhali, Dhaka, going to present my case. Mrs. X, 28 years, para 1 with no living issue, housewife from a middle socioeconomic condition family, admitted in National Institute of Cancer Research and Hospital on 10th April 2021 with the complaints of abdominal distension for 3 months, heaviness in lower abdomen for 3 months, and anorexia and early satiety for same duration. She had no bowel and bladder habit alteration, and she had no family history of breast, ovarian, or colon cancer. She had some investigation. Outside NICRA's ascitic fluid study was done, which reveals negative for malignant cell, and adenosine diaminase reveals normal within normal limit. Her tumor marker CA125 is raised, that is 453 unit per ml. Chest X-ray PA view show subsegmental collapse of left lower lobe. CT scan of whole abdomen done on 15th February 2021, and it reveals mixed density cystic and solid component arising from both ovary. The right one is about 13 into 12 centimeter and left one is about 11 into 9 centimeter, which infiltrating both fallopian tubes, uterus, urinary bladder, and terminal ileal loop. And moderate ascites was present, and there is mild to moderate pleural effusion. The picture shows the pleural effusion. With this report, the patient admitted in our institute, and on admission, the patient is moderately anemic and other vitals are within normal limit. There is moderate ascites and ill-defined mass is felt, which is about 15 into 16 centimeter, occupying whole lower abdomen. On vaginal examination, the mass is felt through all fornices and nodular deposit present in pouch of Douglas. So how will we proceed now?
Do we have any tissue diagnosis? I just missed out.
Next.
Next. And as the tumor is bilateral, so we do colonoscopy and endoscopy, which is normal limit. And we review the chest X-ray on 28th March 2021. And there is a consolidation of left lung with left-sided pleural effusion. Then she referred to chest physician to aspiration of the pleural fluid and study of the fluid, but which is not feasible. Then we do CT-guided core biopsy, adnexal mass, and the report reveals serous cyst adenoma. So my question is, do we need further chest evaluation here?
Anybody from faculty?
Dr. Amita said?
No, Dr. Ahuja, please go ahead.
I'm not very sure about the CT abdomen findings, whether there was only a mass and ascites or were there other metastatic deposits seen on the CT scan. You have mentioned a complex mass in the pelvis with ascites. There were no other deposits seen anywhere. No thickening, nothing.
No, CT scan report did not comment about any metastatic deposit.
Yeah, okay. So, and there was ascites. So, this ascitic fluid cytology, normally, how do? You just, you do a cell block, you take a large quantity of ascitic fluid, centrifuge it and do a cell block, or how is it done?
No, cell block is not done, as the ascitic fluid study is done outside in our institute.
Okay. Because unless there is a metastatic masses seen beyond the ovary, I would not advise think of biopsy straight away, especially if the pleural fluid is indeterminate. Because then if she doesn't have a significant pleural effusion, there's only ascites and a pelvic mass with no metastasis. Why shouldn't surgery be considered? Is an open question.
Amita ma'am, do you like to comment anything?
Yeah, I think, yes, young lady markers were not very elevated. Germ cell markers were normal, I guess, right?
Yes.
Okay, and yeah, there is no metastatic spread beyond ovaries and some ascites and pleural effusion. So maybe a candidate for primary surgery. And ileal loop on a CT scan, I think that's very dicey diagnosis. If clinically there is no symptoms of bowel infiltration, I think I wouldn't really consider that as a significant thing on CT scan. So plan would be exploratory laparotomy now.
Yeah, the idea is a core biopsy would be contraindicated in such cases because
that I think absolute contraindication, no, because she already has ascites and pleural fluid, which of course turned out to be negative. But
Amita, may I make a comment?
Yes, sir. Hi.
Yeah. Hi. So, Dr. Ahuja, the question that Amita raised is a borderline situation. So we understand that there is some ascites. We are not sure it is metastatic or not. Even we do cytospin, 40% of the cases it comes positive, but in many cases it may come negative. So it is not always conclusive. So I think the discussion can be that in this type of situation, when we should go for intervention to go for a biopsy, or when we can straightway go for laparotomy.
Yeah, as I said, if there is no evidence on imaging of extensive metastasis beyond the ovary, no definite metastasis beyond the abdomen, then I would think of, and the general condition is ECOG 0 or 1, I would think of surgery as the primary modality. If she would have had masses beyond the ovary, significant pleural effusion, then there was a different issue.
So, Dr. Ahuja, can I say in a different way that if we were thinking for some NACT or something like that, maybe in that time we will be pushing for some diagnosis. If we can plan for exploratory laparotomy, so this is going to give us a diagnosis. So maybe we should not chase for a tissue because we are not sure whether we are doing some upstaging or not.
That's perfectly right. Because many times you may have an ascites without malignancy, it becomes negative without stage 1 also.
See,
but I think here more important is the...
Can I just make a comment here? Good to have you with us. See, such cases are always tricky, and we should be, we should deliberate and spend time on planning our management. Because first doing a biopsy, then that report is not very conclusive. Then you want to do surgery. Then there's something. Sometimes it's not correct. This patient, we can do surgery upfront for her because, like Dr. who just said very nicely, there's no upper abdominal disease per se on imaging.
And provided her pulmonary function tests are all right, and that we think she can withstand anesthesia, only then, if for some reason we feel that she's compromised, lungs are compromised, or she cannot withstand anesthesia, that is the only time then one would consider doing a core biopsy for her, or a biopsy, and then think of other things. Otherwise, on the face of it, upfront, we can definitely plan surgery for her. So that's what I mean. We should, spend time assessing her before straight away rushing in for a biopsy. That's what I mean.
Looking at her CT images, I will be surprised if final diagnosis remains cyst adenoma. It looks at least a borderline or low-grade kind of tumor. There are significant solid areas, and MRI can be useful in this situation, especially in a young patient. So let's see what.
Amita, what about the lung? I mean, I was not very happy with
this. So I tell you, if this patient comes to our center, we will proceed the same way. We will first do pleural, cytology or ascitic fluid cytology. Of course, we do send for cell block routinely, and our overall yield is very good. If negative, then only we will plan. But I think clinical findings, somewhere it was mentioned that there is some deposit in pouch of Douglas also. So it doesn't look very early kind of disease on clinical assessment, and masses are of restricted mobility with some disease in POD. Of course, we will also do pleural and abdominal fluid cytology first. And if negative and with due this risk, we will plan exploratory laparotomy.
I have a comment here. I have a comment here.
Please.
That's because these patients, their pleural fluid is not enough so much that they could do this, the pleural fluid aspiration and do the cytology. And also, we don't, every patient and minimum patient, we can do the cell block, because cell block is not available in our center. It is only available in one or two centers in our country. And it is so costly that it is 40,000 Bangladeshi taka, then cell block. So maximum patient, they can't afford it. So we cannot routinely do this. In that cases, we always advise for this. In these cases, because there is the restricted mobility, we thought that we cannot remove it completely. So our plan was there, if it is the core biopsy and if it is the positive, then we will go for the neoadjuvant chemotherapy, then followed by surgery.
Okay, right, Shahana. I agree with your plan, and in fact, to tell you, this cell blocks we now routinely do, but I think 5-6 years back we were also not routinely doing cell blocks. We were just sending ascitic fluid for cytology.
Yeah, that is right. And now, see, the dilemma is now we've not been able to do a cell block, and we've done a core biopsy, and we have a cystadenoma as the diagnosis, and you cannot give her any chemotherapy now. You have to do surgery. Okay. And you have to do a frozen section of that. And again, if it is borderline, you may get a correct frozen section report, or you might not get a correct frozen section report. So all these issues.
Okay, we are coming. Dilruba, please.
Since she underwent laparotomy with frozen section on 19th April 2021 in National Institute of Cancer Research and Hospital. Her perioperative findings was ascitic fluid was present and sent for cytology. There was bilateral ovarian tumor. Right one is about 16 into 15 centimeter, lobulated, capsule was ruptured, and tumor on surface. The left one is centimeter and with intact capsule. Exploration of the abdominal cavity was done, and there was metastatic deposit about 4 into 3 centimeter in the vesicouterine pouch. Another mass is found in the pouch of Douglas. And the terminal ileum also amalgamated with the mass, and few deposit all over the pelvic peritoneum. Finally, total abdominal hysterectomy with bilateral salpingo-oophorectomy, pouch of Douglasectomy, removal of all macroscopic metastatic deposit with pelvic and para-aortic lymphadenectomy, omentectomy, and appendicectomy was done. This is her perioperative findings. The larger one is light ovarian mass, and smaller is in left ovarian mass. After resection of the mass, this is right ovarian multicystic mass. And after resection of all metastatic deposit, this is the final picture of our pelvic cavity. That is after anterior and posterior pelvic peritonectomy. And final histopathology report reveals the papillary serous cyst adenocarcinoma of the both ovaries and peritoneal deposit showed metastatic adenocarcinoma. So, as the patient is young, belongs to middle socioeconomic condition status, and BRCA testing is expensive. Should we go for BRCA testing for the?
So the answer is, if, for her, we are not talking, if she cannot afford, we cannot. And therapeutic, if she can't afford tests, definitely she will not be able to afford treatment related to BRCA positive, like, PARP inhibitors.
Absolutely.
So,
better to spend on the chemotherapy rather than on BRCA testing.
Right. So that's the thing. If she, tomorrow, if test cost come, is less, or if she can afford, we can do it later. We may not do it now. We just keep in mind that she's a young patient and we may offer it at a later date.
Dilruba.
So essentially, final stage, momentum was negative and nodes were negative. So she had only disease in the pelvis.
Yes.
Right. And they're not specified what was it, a serous tumor or?
Papillary serous cyst adenocarcinoma.
Okay.
What about the chest status, and how did that fare? Because there was consolidation of the lung and this pleural fluid. What happened to all of that?
Metastatic deposits show metastatic adenocarcinoma, but after in her postoperative period, we cannot evaluate her chest. It is her 10th postoperative period. Today is her 10th postoperative period.
But, as like Rupinder, I want to mention that before surgery, we should have gone more extensive evaluation of the lung, like a CT scan, because there was a X-ray chest was telling a consolidation. Sometimes we don't know what it is.
CT
Maybe
was done, Dr. Kamal.
Yes.
CT was done. Yeah, it was done.
I see. Okay.
Yes.
So did they confirm that it was a consolidation in the CT or only effusion?
There was some consolidation.
Consolidation also.
So, Amita, in this type of situation, maybe she's lucky, but in CT, when they are telling consolidation, we should be very cautious, because whether it is effusion and consolidation or whether there is a metastasis, that could be a possibility, isn't it?
Yes.
Yeah, that's right. And the anesthesiologists, they were happy to take her up for surgery with a consolidation.
Yes.
Maybe they were scared of Shahana, so they agreed to take her.
we did not factor that, but yes.
Yeah.
It's nothing. There is no alternative, because we request always, there's some missing with anesthesiologist. There's we request that we have nothing to do. So in this situation, what can we do?
But I'd just like to say it was a very optimal surgery done. We should congratulate you on that. And now you're planning for adjuvant chemotherapy.
Yes, sir. Yes.
So, Amita, Dr. Chakwe is also here. Say the patient is not rich. So if the good surgery is done, let us forget about BRCA. BRCA is fine, BRCA is positive or negative, but even I think she has a good chance if we, as good surgery is done, if we get a good treatment, I think there is a fair chance for her. What do you recommend?
Yeah, I agree. I think she should, get standard chemotherapy and be on follow-up, yes.
Yeah, because this BRCA issue came only a few years back. Before that, we were happy with this type of good surgery and good chemotherapies. Because the problem is here always now we are chasing with this type of PARP, because as Amita was telling, even with the generic, it is most of the patient cannot afford. Even they start, they cannot continue. Even for 2 years, majority patient cannot do. So maybe sometimes it was better not to have something. Where we have something we cannot offer. That is a big cost for us.
Kamal bhai, we have another faculty today. She is Dr. Seema Guria. She is Professor of Medical Oncology from Tata Memorial Hospital.
So she is from Mumbai?
Yes, Mumbai.
Okay, Seema, welcome to our program.
Hi, thank you, sir.
Hopefully one day we'll meet.
Yeah.
So I think that Shahana is discovering all the faculties of India and bringing them in. So Shahana, is it? Are you finished?
Yes,
no,
yes.
I have another question to Amita ma'am. As the patient is young, there is any role of hormone replacement therapy for this patient?
Okay. So theoretically speaking, yes, we can do hormone replacement therapy, but in our practice, we do not start in HRT immediately. We generally wait for 2 to 3 years before starting HRT, and some of these tumors, although it's a high-grade serous carcinoma, but some of these high-grade also have estrogen, progesterone receptors. So we don't do unless patient has very acute symptoms. Then also we try to manage without hormonal therapy. We give non-hormonal treatment to these patients. I don't know what is Dr. Rupinder and Dr. Ahuja's practice, but that's what we do.
I agree with the 2-year part, but I have another reason also for that, because especially these high-grade tumors, which are stage 2 and above, the chances of relapse are there. In the first 2 years, we know 80% would relapse if they have to relapse. So waiting 2 years would tell us that this patient is going to live long enough to benefit from hormone therapy. So that's a good practice to delay hormone replacement therapy for 2 to 3 years.
Yeah, I agree on both accounts. Actually, these patients, they come back very fast. So these are very aggressive tumors. And one is so busy, thinking about how to manage the recurrences. We hardly ever give, the poor things, they hardly reach that stage where, you need to start considering hormone replacement therapy and all. It's only the stage 1A or maybe some of stage 1C tumors that one really needs to give a lot of thought to. Should we give hormone replacement therapy to them or should we not, or that kind of a thing. But for such patients, it's a little difficult.
Yeah, although books write that in high-grade serous young patient, you can start HRT immediately, but I think none of us practice this.
Yeah, absolutely.
I don't know what is Dr. Shahana, your practice?
Yes, we do also like this. Yeah, usually we don't offer the hormone, and even usually the symptomatic treatment we advise the patients.
Yeah.
Dr. Shahana, Dr. Kamal, and everybody else, Dr. Ahuja and Amita, Dr. Chaku, I'll have to leave now, please, if you don't mind. Yes. Thank you so much for inviting me. It's always a pleasure.
Thank you.
Bye.
Okay, bye. Good night.
Thank you, Rupinder. Thank you for joining.
Dilruba, any other question?
Yeah. No.
So,
thank you.
Okay.
So
stop your screen sharing. Yeah.
Very nice presentations. All three were very good.
Very much.
Thank you, ma'am.
Dilruba, stop share your screen. Okay, Shahana, I think you can wrap up now.
Yes, before that, we have some local faculties like Dr. Parveen Akhtar Banu ma'am, and also from the Kudrati Elahi sir. And I would like to request them to comment to this presentation.
Banu Appa, any comments on today's presentation?
Thank you, Dr. Shahana. All three presenters are very nice. Their presentation are good, and the session are very interactive, especially our foreign faculties. All foreign faculties, their discussion was we highly enriched our knowledge, and I think that our residents, including ourselves, we are really benefited with all the discussions. So thank you, all the foreign faculties, And also thank you our local oncology club organizer, especially Dr. Shahana, for this session. And it was really, really very highly appreciated episode. Thank you very much, Dr. Shahana.
Thank you, madam. Thank you very much. But before concluding, we have the poll questions. And Shorna, please show the poll questions again.
So Shahana, during the poll, I want to say one thing, that the CT scan, that the last case, we were discussing on the report. I think we should start reading our own CT more delicately, because sometimes the radiology colleagues don't know what we are looking for. So maybe if we can really read the CT more details, maybe sometimes we will not miss this pouch of Douglas thing that was mildly mentioned, not very severely, and found out that that was the main area. So I think there is the area we need to work on, radiology and pathology more in our area.
Yes, Dr. Kamal, that is very right. Because many times we actually find out the pathology and we ask our radiologist to review the film. So it is, I think, comparatively easier to, read CT scan, but MRI not.
MRI is, madam, agreeable. That is, to us, we are more comfortable with the CT, but I think, as I'm mentioning, that the juniors should be focusing more on the imaging, and they should be, I mean, Dr. Ahuja was very categorically from the beginning, he was telling, there is nothing on CT. Is there anything on CT? So we need to trust on this before taking a decision. So I think there is an area that our junior colleagues need to really work hard as a clinician to work more on CT MRI. So that should, I mean, somebody said that you need to read.
Yes. Actually, during residency program, it should be incorporated in the training, so that 2-3 months they go to learn, reading the CT scan and X-ray. I mean, radiology department, they should be on rotation. So in our time, we had this, rotation in radiology during our residency. So I don't know here, but it is really helpful.
We have our residents, they have the rotation in 2 weeks in radiology department.
I would just like to make one suggestion here, like what we have been doing with our trainees. Before any surgery, we go through the images with the trainees and the residents before opening. So the entire discussion about findings are done there. So on a case-by-case basis, rather than the juniors, the students can go to a department and come back, but then later case-by-case training, the faculty has to give them.
Yes, always we do this in our hospital. We always do this.
Okay, Shahana, go for the poll question.
Second question, please. Shorna,
So,
second question.
So this is the real life teaching that Dr. Ahuja was telling. You see the image, they go to the OT, open the case, then match with the image and the real life findings.
%62% correct question, sir. Then third question. Okay, thank you very much. Yeah. Now I would like to in the session before that, I would like to request our scientific secretary, Dr. A.F.M. Kamaluddin Bhai, to give vote of thanks and conclude the session.
So thank you, Shahana. I think it's very late. It's 10:30 Bangladesh time, so 2-hour session. Thanks to the presenter, even I missed the first two. And definitely the credit goes to you for bringing all the big stars like Dr. Ahuja, Amita, Rupinder. And also today we have a new Dr. Chakova. They are our old faces, but today welcome to the new faculties, Dr. Seema from TMC, so TMH. And I'm sure everybody enjoyed it. And this endeavor has been going on to see the real life scenario and discuss, because formal teaching and real life scenario is totally different. Here, all the issues come and we can discuss and we can take the knowledge from our colleagues from overseas. And thanks to all the friends from overseas who have been helping us for last more than a year for carrying this forward. And I'm sure your support will continue so that we can continue this endeavor. And definitely Shahana deserves a big congratulations for carrying this program. And finally, all the participants, like 150 participants was there. So they deserve the credit for making the program successful. Oncology Club is continuing this program and is planned to continue. And our main objective is, we know that building can be made, equipments can be brought, but we need quality trained manpower to give the good treatment. So that's why we need to have trained manpower, and Oncology Club is working for that. And in this endeavor, we are thankful to all the persons from home and abroad who have been supporting. Hopefully next Tuesday, we will have another exciting session. Shahana, are we going to have the next Tuesday session or no, after it?
Yes, we have another session next week. There is the end of the endometrial carcinoma session, and next week is the last session where there is the adjuvant treatment for the endometrial carcinoma and also the sarcoma.
Okay, so I was thinking that before Eid, there will be another program. And after it, we will have a summary program on endometrial carcinoma, like the service that we did. And we will discuss some real life cases. And we will try to get the input from all the local and foreign faculties. Till then, see you all virtually next Tuesday. Stay safe and stay healthy, because you need to be safe and healthy to take care of your patient. Good night.
Thank you very much. Good night.
Night. Thank you.
Thank you and good night.
Okay, Amita.
Okay,
take care.
good night, you too. Bye.
Good night. Bye. Bye.
Shorna, show the poll winners. Shorna, please. Yes, there is 3 winners, Dr. Aisha, Dr. Fatima, and Dr. Mahanas. All the winners are requested to put their phone number on the chat box. Dr. Aisha, Dr. Mahanas, her phone number, Dr. Fatima. Dr. Fatima, are you here? Dr. Fatima?
So congratulations to all winners.
Yeah, congrats to all the 3 winners.
This is
So
pre-Eid gift.
Yeah, pre-Eid gift. Yeah,
pre-Eid Eid.
Eid, yeah, true. So how things are there? A bit better, Amita?
Bombay, I think is little better, but Delhi is Delhi is still
Yeah,
shortage of everything.
Yeah, and now the thing is coming up in Calcutta, I think the West Bengal.
Yeah, Calcutta, it's now increasing.